Hey, welcome back to The Long Game. I'm your host, David Pardo, and today I'm joined by one of the most forward thinking voices in digital health, Dr. Joe Kvedar. Dr. Kvedar is a dermatologist by training, but his impact on healthcare goes way beyond that. He's a professor of dermatology at Harvard Medical School and has served in leadership roles at Mass General Brigham for decades, including as vice chair of dermatology. He's also the editor in chief of NPJ Digital Medicine, a highly respected journal on digital health, and a senior advisor at the American Telemedicine Association, where he's twice served as board chair. In this episode, we dig into telehealth's pandemic fueled rise, why it surged, where it's plateaued, and why it still isn't reaching its full potential. We also explore AI's role in healthcare, what it's great at, where it still falls short, and how specialized models could transform care delivery. And for those in long-term and post-acute care, we discuss labor shortage, the financial incentives behind digital health, and the real business case for adopting connected care solutions. Dr. Kvedar has spent the last 30 years pushing the boundaries of what's possible in healthcare technology, and he's got some strong insight on what's next. So, without further ado, Dr. Joe Kvedar, thank you so much for being on.
Hey, it's a pleasure to be with you today. I can't wait to dive in.
Same. So I'd like to open by saying that you are a trained dermatologist. You are an accomplished dermatologist. You variously chaired or vice chaired the Department of Dermatology at Harvard Med and Mass General, and somehow you are also a big advocate for connected health and telemedicine and the emerging arenas of technology and remote patient care, etc. Can I ask you, how did dermatology lead you to this place?
Yeah, thank you. It's a fun question. So I started out like many people after my residency, which was in the Harvard system. Pretty much everyone there gets invited. Not everyone accepts, but everyone gets invited to do something in basic science. It's just part of the DNA of the organization. We have Nobel laureates running around. So I had a lab for 5 years in the area of uh, epidermal barrier function. And it just wasn't doing it for me. It was not fulfilling as a way to spend my creative time. So then I kind of bounced around for a little bit. And One of the things that my department chair at the time, because he was kind to me, he offered me some things to do to kind of see if there was anything that would catch my fancy other than patient care. And one of them was this idea of digital imaging in dermatology. And at the time, just to give you a perspective, digital imaging, A, was a new technology, at least out of radiology. Radiology always has been ahead of everyone and all of this stuff. But it was new outside of radiology. And the camera that we used to do the experiments we started with was 1 megapixel and cost $12,000 and was about the size of a shoebox. But the idea was, could we take diagnostic pictures with that camera and have a dermatologist who wasn't on site with the patient make a diagnosis? And Lo and behold, while we were doing that experiment, it really was uh, fundamental to me to think there's so much more to be done than just pictures of skin. So that's how I got launched on this other part of my career.
So incredible. I'd love to talk to you about medtech, permutation technology. You wrote a book, The Internet of Healthy Things, where you made a lot of predictions about where we'd be by 2020. We are now in 2024
Yes.
with a lot of unanticipated, completely unexpected, world changing events between then and now. Are there any claims that you think you overstated? Are there claims you think you understated? Are there ones you'd revise now?
Well, I would say I'm generally an optimist. So I look at the things that were right. I also I don't think it was the predictions weren't to me anyway. As I think about writing the book was written in 2014, came out in 2015. So I'm thinking more, not definitely 2020. And I just say that because 10 years out, most of the stuff has come true. And at the time, it really was fantasy. The story I like to tell in this regard is that chapter one is sort of an introductory chapter to the whole concept. Now, mind you, Internet of Healthy Things was a catchy term then, and that's one of the reasons the book did reasonably well. Today, we would call it multimodal AI because that's really what we were talking about. We're talking about inputting your step counts, anything from wearables, maybe your purchase history off your phone, your geolocation from your phone, maybe stuff from your medical record, et cetera, et cetera, et cetera, and coming up with an agent that would guide you to healthier behavior. And sure enough, today, those products are on the market. They're not widespread. They're not in use everywhere, but they're on the market, and there is early success with those kinds of products. So the fundamental notion of the book we got right. Did we get some things wrong? It always takes longer to do certain things, etc. But I think we were pretty well on. And funny you bring it up because I'm now thinking about writing not another book, but sort of a maybe just a quick update, maybe an ebook to sort of go through it and say what we did wrong and right.
Amazing. Okay, here, announced it here on the long game.
Thinking.
Thinking
Yeah,
about it. Okay.
yeah.
Would love to push you in that direction. The Internet of Things is definitely a term that's fallen out of use. The concept is certainly ubiquitous, though. I think everyone knows that the power goes out. That means that they suddenly don't have access to, well, not the power. The internet goes out. You can't turn your lights on and off anymore. You can't change your thermostat's gone. All these funny things, and you can't buy a watch anymore that doesn't tell you what your heart rate is. Uh, not outside of luxury watches. You mentioned AI just now early in our conversation. I was waiting for later to ask you about that, but AI is another term, super ubiquitous. And the truth is, we when we talk about technology in medicine and we talk about med tech and remote patient monitoring, none of that is necessarily AI. There's a lot of ways of maintaining relationships with keeping track of your patients remotely without having to touch AI. But it's there. So I guess my question is, I know you've spoken about this recently. Um, is AI the answer? Where are we underestimating it? Where are we overestimating it?
Hmm. Yeah, it's a complicated tech, and it's not a smart. I mean, the answer is not straightforward. So I would separate the back one something else I think we're going to talk about is telehealth and the pandemic, and just a quick digression to say now when I talk to patients and I offer them a virtual follow up visit, they know what I'm talking about, and they assume it's going to be a video interaction. So the analogy with AI is when you say AI now, people think it's large language models or chat GPT or generative AI. And that's because it's almost like magic. That's a powerful tool, and it's very sexy and draws you in. But there are other examples. And I think, one answer to the question is if the material that you're working on, and once again, radiology here has the lead. If the material you're working on is images, of course, from a computer's perspective, are millions of little numbers. And it's very easy to use traditional artificial intelligence techniques like machine learning to assess a large group of those images and predict and make predictions on the future based on them with reasonable accuracy. The large language model part, though, is still a little bit rough. And, the idea that makes it challenging is the big one anyway, is that you can ask it questions. And if you're not an expert yourself, it will give you an answer. It does not want to say, I don't know. You have to tell it. If you don't know, say, I don't know. Otherwise, it will give you an answer which could be completely made up, and it will state it with great authority. And if you don't know that, you could make serious errors in whatever you're doing. Medicine just being one example.
I assume it learned that from humans. It's not specific to AI, this problem. But yes, it is a
Yeah.
big problem.
So that's the biggest challenge with generative AI right now. It has enormous potential. And I'm one of the other hats I wear is I'm editor in chief at Nature Digital Medicine, and maybe 70-80% of our papers now are that are submitted are AI, and of those, probably at least 50% are on generative this or that, or large language models this or that. So the amount of research and change is stunning. And again, the opportunity for us to use those tools, but it's just not quite there yet. We have to be a little more patient, do a little more um, clinical research, testing, et cetera, before we roll them out in large ways.
So that's the limits of generative AI, meaning that it's not there and it still hallucinates and it won't acknowledge when it's wrong. Have you ever tried Notebook LM, by the way?
Yes, I did. Yes, so my colleague, I didn't do this, but my colleague, a mentee rather of mine, took, I think my second book, the New Mobile Age, and
And fed
either
it to
that
Notebook
or
LM?
sorry,
And fed it to Notebook LM?
yeah, and then generated a podcast of someone discussing my book.
Okay, so it happens to be that you can create a like top tier 16-minute podcast out of it, and
Yeah,
that's pretty cool. But also, you can ask it questions about the training data, and it will absolutely tell you. I don't know if it's outside
yeah.
the. It's a very small training set. It's whatever you give it. You can give it 10 PDFs and a YouTube video and a couple websites or an audio clip. But it'll say, oh yes, this is the answer, and it'll tell you where it's from. Um,
Yeah, I think the other example of that is there's one. I'm a dermatologist by training. You mentioned that, so I have this one that one of my colleagues developed called Derm GPT. This woman simply trained the GPT on a very relatively, I shouldn't say very, relatively narrow data set of all the dermatology literature. So I have that thing open when I'm in clinic, and I'll ask it questions. I'm pretty confident in the answers because A, it does say sometimes I don't know the answer, but B, uh, it's trained on a very, again, more narrow data set. So I think you can be a little more confident in what you get. And you see other examples of this now where people are training these same technologies, but not on the internet. GPT-4 is trained on the whole internet. So it's going to make mistakes.
so that's LLMs. Have you been involved with machine learning and compiling large quantities of data, not just from individual patients, but from broad ranges of patients to create predictive models? Or do you have strong opinions about
Well,
overestimating,
first of all,
underestimating there?
I'm not a data scientist. I have zero computer training. I've just been uh, interested in how these technologies can make healthcare a better place for 30 years now.
Right. Yeah. Sorry for pushing you there. You had
No,
a
no,
podcast
I just
recently
want to
on AI, so I figured.
yeah, I want to make it clear to your listeners that I don't speak from the point of view of someone who can actually code or has a training of a data scientist. Yeah, well, again, I'll use my own field as an example. In 2017, there was a breakthrough paper by some folks out of Stanford, which showed at the time it literally sent shivers through the profession because it showed that a computer model could predict melanoma as well as or better than a dermatologist. But the caveat is that from an image. And I say that because we haven't yet got to the point where first of all, it's not that useful. I'm pretty good at predicting melanoma. It might be useful for a primary care doctor so they don't have to send me patients. But again, you have to know how to take the image and so forth. So there's a little bit of a gap there between this, once again, which seems like magic and the reality of working in the clinic. Now, there are other, examples now in the marketplace and in the lab of being able to predict psoriasis, being able to predict eczema, being able to predict inflammatory skin conditions, which, as I say, I think will eventually wind up being of use to primary care doctors so they don't have to necessarily refer everything. Or when they do make a referral, they can be more targeted in what they want. Um, so,
So you mentioned COVID-19. I'm curious. about your thoughts. Where did the pandemic accelerate telehealth adoption, and what lessons do you think we learned correctly or incorrectly?
Yeah, thank you for that because I have spent some time thinking about that. So I'll start with some stats. In 20, well, I'll even back up and say that the stats come from a website called fairhealth.org. It's the Fair Health Tracker. It tracks medical claims in all sorts of different ways, insurance claims. So in 2019, in August, the amount of telehealth claims was 0.19% of all claims in that month. It got to, and remember, claims are usually 2 to 3 months behind what's happening. So if I say claims in August or data in August, it's really reflecting data in May and June. So in August of 2020, 7%. That's as high as it ever got. And then January of 2021, back down to about 5%. And it's been stable since. So you could say, one answer to your question is we had a 25-fold increase in telehealth, and it's been steady. So maybe some people would consider that a victory and go home and you don't need me to be an evangelist anymore. I don't think we've reached our potential, but that's maybe for a different question. So there's that just basic fact. Now, if you break down that 5.5% of claims that I mentioned, 80% of those are behavioral health. So the one thing you can take away is that the big winner from I'll call it the pandemic experiment with telehealth, has been behavioral health. And God bless them. So many patients benefit from that, right? That there's still not enough behavioral health practitioners to go around, but people can now access behavioral health services in a much more convenient way, and everyone wins. In the state of Massachusetts, where you and I both live, it's a state law now that insurers have to pay for behavioral health consultations at the same rate they pay for in-office visits. So big deal. Now, again, I think we there are other, and everything after behavioral health is 20 more percent, but everything else is like onesies and twosies. So it's a scatter shot. So I do think we have a long way to go. Some of the lessons learned, well, I mentioned one earlier, which is patients know what this is now. That's huge. Um, I worked at the Mass General, now called Mass General Brigham. Back in the day, our corporate name was Partners Healthcare, and I would go around giving talks, and I'd say I spent 10 minutes explaining partners and 10 minutes explaining telehealth, and then my time is done. So I got that second one out of the way now. Everyone knows what it is, or at least they have an idea. Um, what I think didn't go so well was the fact that we did everything all at once. And there's so many examples of interactions with patients that do require you to be in person. The reason behavioral health works is because this physical exam in that specialty is talking to the patient, which you can do quite well over a video call. Some even say an audio call, but it's certainly a video call. Whereas let's say I'm myself a dermatologist, I do little biopsies, I do little freeze little things, I do things in the office. So send me the wrong person by telehealth, and it's a big disappointment. What I've done, and after we are finished today, I will go do telehealth the rest of the afternoon, as I curate patients who I know will benefit from that experience because I don't have to touch them, I don't have to do a procedure on them, and everyone wins. I have kids who are in sports stop their practice, go to a quiet place in the locker room, and take their telehealth visit. I had a guy the other day who was driving. I said, please pull over. But the fact that he could pull out his phone during traffic and do his telehealth visit, again, I'm not advocating, just saying how convenient it is. So there's a huge convenience if you choose the right stuff to do it. But what happened when we did everything that way was certain doctors, yes, certain doctors were like, oh, wow, I can do this. This is good. I'm going to integrate this into my practice. But certain doctors were frustrated because, again, they felt like the use cases that were chosen were not the right ones for them. That leads to a phenomenon that we're seeing now, I think, which is in certain cases, both the people scheduling visits, the staff, the physicians, clinicians are treating it as if it's a second level of care because you can't get in to see me, but I can do a video. And if we start sending that message to our patients that this is sort of second class care, that's a bad outcome from the telehealth experiment.
You mentioned seven in the beginning, about 7% of claims. That's and that Dr. Kvedar's out there saying that's not enough. What is the utopian flying cars version of we got telehealth right and remote patient monitoring and connected health? What does that look like?
Well, again, I'll speculate. I do often when I'm out on the stump speaking, I will remind people that we don't know the answer to that. That's one of the things that's a little bit annoying is that there is nobody's done the right amount of research to sort that out. That we start from a place where most clinicians believe that they're going to do something better magically while the patient's in front of them. They have this innate kind of untested gut reaction that you should be in the office. So that's a starting point. There's a starting point from the facility perspective, the hospital. It's more profitable for them to get you into the facility. So there's that. So
It's
a
more
couple things.
profitable because of reimbursement rates, or
Yeah, it has to do with reimbursement and ancillary services. Like if you and I were having a visit today and I said you need X, Y, and Z labs, you could go to LabCorp. But if you're in the hospital, you're going to walk down this hall to the lab.
yeah,
You
and
need an X-ray,
I'll
you
pay
go
for
to my
parking.
right. So
I'll stop at the cafeteria.
maybe, but anyway, so those are some just overall thoughts about what's holding it back. And again, I don't know the answer. I do know that one of the things that I've done now for at least a couple of decades is look at other service industries and how they're adopting technology. And one of the fun things about that is I can sound like I'm a predictor of the future because I just look around me and we're always 10 years behind everyone else. So the scenario I would give you is number one, you, David, if you have a healthcare problem, you reflexly go to your mobile device. I mean, you might go now to make a call, but you don't go there typically to solve your problem. So that's step one is we need to make it always on, mobile, easy to access, and useful.
David's actually a bad example because all of David's labs are right now in ChatGPT in the memory,
Okay.
and
Well, fair enough.
ChatGPT is with me in my doctor's
You are
visits as
you are
well.
not a good example, but
Yeah,
most people.
yeah,
Um,
sure.
so that's one. The second one is once you get to that mobile device, there's some, to the point we're talking about earlier, there's some chat bot function that takes work away from because the other fundamental problem we're all needing to solve is that there's not enough healthcare providers to go around, whether it be nurse practitioners, physicians assistants, doctors, nurses. We're all in short supply. So if we can get software that helps you solve a problem without getting it to me, that's a societal win. Right now, that doesn't work very well. It doesn't even work very well in computer customer service for Apple or something like that. So long ways to go. But as we were talking about, AI is fast accelerating. Maybe we'll get there. I don't know. Maybe in 10 years. Maybe that's the next step. Um, so something in front of you and then that software can do a bunch of things. It can tell you which urgent care setting is open and which one has the shortest wait within 10 miles. Again, not a new technology. You get that all the time for Yelp restaurants and things, but we don't do it in healthcare. It can schedule something for you tomorrow with your doctor. Not It's in use some places, but not widespread. Most of the time, you have to phone someone to get a schedule. Again, open table exists. We don't use stuff like that. Not widespread. Um, it can decide whether your problem needs to go straight to the emergency room, whether you can go to urgent care, or we need to need to show up in your doctor's office tomorrow. Um, that kind of level of decision making should be something that a bot could do. And again, and then direct you and say, David, you need to go into the ER. The nearest one is Melrose Wakefield Hospital. And right now they can see you in 30 minutes if you get there in 30 minutes. So, and of course, in there is things like a video visit. Sure. In there is things like the fact that you have an Apple Watch and it's found out that you might have an arrhythmia. That's why part of this whole thing maybe got started. Is it dinged and says your heart is not beating right? You might have atrial fibrillation, and you go down a decision tree based on that. Um, so all those technologies, like again, virtual video visits or chatting with your doc over a secure text interface or remote patient monitoring or wearables, fit into that scenario. But it's really about delivering you the best care in the most efficient way without you always having to leave your seat to get it done.
Uh, Crazy how far ahead the hospitality industry is. Every example you mentioned was about restaurants.
Yeah,
It's true.
yeah, yeah. I know.
Yeah, you open Google Maps and it'll tell you this restaurant is busier than normal or less busy, or it's pretty remarkable. But you also mentioned that it's a preponderance of healthcare providers, doctors, NPs, PAs. Um, will there ever be enough providers, or does the existence of more providers somehow create more demand?
Well, you can answer that question in two ways. One is the answer is no. We can't train them fast enough. The onslaught of chronic illness is upon us, and the curve simply can't. The rate at which we can train people will never keep up with the demand, especially in the zone of chronic illness.
Is that because we're living longer? Is that because we're less
Yes,
healthy?
yes, both. But yeah, we live longer. When my grandfather uh, was alive when they created Social Security, and the average uh, age of a man at that time was 62. And if you made it to 65, they gave you a little extra, money you could retire. Now, of course, the average age is 78, 79, whatever it is. So, yes, all those things and yes, there's more unhealthy lifestyles, there's more of all that stuff. Um, and that's not the only thing we of course need healthcare for, but it's a huge burden and it is something that we can't solve with more people. The second point I'd make is, again, in any industry, including healthcare, the biggest expense is labor. So why would we want to add more labor when we already spend more than any other country and we get fewer poor outcomes? So we've got to solve the problem with tech.
Tech is always the answer to the labor capital trade off.
Yeah.
Um, okay, between being editor in chief at NPJ Digital Medicine and your podcast with American Telemedicine Association, available wherever podcasts can be found, you are very on top of the trends. Um, what do you what do you think is not being discussed enough?
Well, I already mentioned one, which is this idea that video visits should be part of an omni-channel service offering, not just a thing that you plug in and don't think about. Back up even more and say, what other industry thinks about a physical interaction as the thing? Which, again, in healthcare, everything is based on a quote, visit, end quote. That's two people getting together in some way. It used to be in a facility. Now we could do it this way, video, that's a visit. But it's this
I
idea
will
of an
say,
interaction.
ironically, another industry that thinks in person is better is hospitality and restaurants, but
Fair.
ironically has way more going on in terms of integrated technologies, and so
Yeah, the other
interesting
one that
analog.
I used to say that I would say I can't think of a service that you now consume that you don't go first to your phone. The other one is getting your hair cut because I discovered that during the pandemic too. So yeah, there are a few examples, but for the most part, everything you do nowadays is, again, it's that model that I described earlier. So what's not being talked enough is how we as healthcare providers need to get out of our own way and think differently about service delivery, train our staff differently, Now, there is another barrier which just happened in DC. I don't know if your listeners were tuned into this, but since the pandemic, we've had regulatory relaxations around telehealth reimbursement. Um, and every year or two, Congress, and they do this as so many different things, will do what's called a continuing resolution and say, yeah, we'll do that for another year or two. And sure enough, that was teed up until our president-elect killed the bill that he killed. And what ended up happening was the Medicare flexibilities are now on through March of 2025. They'll get renegotiated. I'm sure it'll be fine. But if you're in my part of the business, which is a healthcare provider organization, it's really hard to make a big investment in a whole new omni-channel strategy when you're not sure if you're going to get paid. So that's a challenge, and so I think what's not being talked about enough. We talked about it earlier, which is a supply and demand mismatch. The only way to solve it is with tech. People are really afraid of tech, whether they think their jobs are going to get taken or we need that good old fashioned Marcus Welby human interaction, which by the way, I love patient care and I'm a big fan of interacting with patients. So and again, robots can't do what we do as doctors. They
Of
can help,
course. But
but
they can leverage. That's I think that's the
yeah,
name of the
they
game.
can help us, but they can't do it. So it's really that. I think the fundamental thing that isn't talked about enough is that supply and demand mismatch, that we just can't solve it with more people. And that's what we keep trying to do.
And the only way to solve it is technology, and the only way to implement technology is make sure it's reimbursed at a fair rate.
Yeah, it's what I call one to many thinking. And again, every other industry that you can think of does this already, call centers. If you go to any retail outlet now, there's one cashier and about 10 cash registers. Didn't used to be that way. You pump your own gas, you check yourself in at the airport, all these examples where you do the labor that when I was a kid, people did that labor. Healthcare hasn't gotten there yet. And so one to many thinking, remote patient monitoring and wearables is a great example of that. I can monitor, I should say, monitor. This isn't me making stuff up. 300 or 400 heart failure patients per one nurse because we're managing by exception. Those people are all being monitored in their home. And if they have something that's out of whack with their vital signs, a nurse gets notified and that nurse will call them and walk through what needs to be done, see if they can keep them healthy in their home, avoid trips to the emergency room. Those kinds of programs are what we need to think more about. And it's hard again, it's not a visit. So how the heck do I work that into my business plan? It's complicated. And so now we do have reimbursement codes. Something else I'm involved with is I co-chair the AMA's Digital Medicine Payment Advisory Group, and we are the group that put through those codes for remote patient monitoring, which are not perfect, but they've accelerated the adoption of that industry. Um, so there are ways now to get paid for that, but it still need to get paid for it and think about it's valuable for me to do what I said, which is if I have 300 heart failure patients and I don't get them in the office for anything, how do I make a living? So again, other industries have figured that out. We're stumbling over it in healthcare right now.
Did we figure out in other industries because of the economic structure?
Yeah, I think so. The one that people talk about the most, because really about interoperability, is financial services. So we'll put that aside. I still like to have a conversation with my financial services person at least once a quarter, but we do a lot by email, and I dare say a lot of what they do can be done by software. Um, but just so many other industries, in order to keep their prices competitive, have again they've gone to using computers and software to do things that human beings used to do. Um, so
Right. That's because you're paying for the either the wealth manager or for the app that does the wealth management, or you're paying for your airplane ticket, or you're paying for check-in services or extra whatever it is. But with healthcare, no one's ever sure who's paying or who sets the prices or um,
Yeah, there's that. And I think the other thing is that, well, something I said earlier, which is the bot part. We haven't come close to getting that right in healthcare. It's anything that I've seen doing that is offensive as a patient.
The bot part? What do you mean bot?
Yeah, the part that
Where I chat with a bot to
you
find
chat
out.
with some software ahead of time to get your problem started.
Yeah,
We and so people are like, I want to see my doctor, and I kind of don't blame them because right now we don't do that part well. So that's a big efficiency gain. Again, it's working on it is hard because people are like, okay, well, how do I make a living building software that allows doctors to work less? Um,
yeah. I'd love to pivot. Not really. It's not really a pivot, but a lot of people who listen to the podcast are specifically in skilled nursing, where like there's no private pay, meaning everything comes down to reimbursements. So if you have their ear and you're trying to advocate to them, um, why me- you're advocating for telehealth because it'll improve patient outcomes. But for someone who's, let's say, the CFO of a large nursing home group, where they're looking at the bottom line, and what's the argument for them to start investing in connected health technologies?
well, I think what you say is you choose, and CFO is a great conversation. They're always fun because they're so objective, and all they will talk about is. And again, I learn a lot from that because the rest of us who do hand waving and we're visionaries and this and that, they're very practical people. So, what I would say is think about the processes in your organization that will allow you to use your labor force more efficiently and start with those. So, a lot of that turns out to be back office stuff like a robotic process automation and stuff. Not very sexy,
Right.
but
Or AI patient intake forms,
yeah.
those
So,
sort of things,
again,
scanning.
not the sort of stuff we've been talking about, the vision of the future, not, but really important. And the other thing about that industry, not just that industry, but any healthcare industry, is that the people delivering the care get annoyed when you present to them that maybe a machine can do part of their job because they're all caring. The reason we all went into this almost universally is because we care about people. We want to help people. We enjoy, and again, God bless the people in skilled nursing facilities. That's a tough job, and yet they keep it doing it because why? Because they want to. They get some good out of it. It's uh, there's a give and take to it. So you say, well, you know what? We're going to have you take on 10% more patients on your shift, but we're going to do this thing in the back end that makes you more efficient. That doesn't sell well. So you have first the CFO, but then you've got to go back to the frontline workers and help them realize that you're not just trying to suck more energy out of them, that you really want to solve a particular problem and get their buy-in to solve it. So
Driving to the same bottom line
yeah,
by a different
it's
route.
so, yeah, and it's hard. I think it's funny because in healthcare we have this funny thing about um, and science too, really about profit and not for profit. Um, and so the media, the CFO is all about again the bottom line, appropriately, no margin, no mission. But people on the front line get annoyed with that. They somehow think that's filthy. That someone will put money before my job, and yet could I please have a raise? So it's it's something that probably roots back to how we as human beings are always uncomfortable talking about money with other human beings. I don't sure why that is. That's a off point here, but
Um, Dan
but
Pallotta has a book where he attributes it to the Puritan roots of America.
sounds right. I mean, it's just so fundamental. But anyway, um, that the CFO was part of the challenge, which is again make some investments in these things because they will help you run your organization more efficiently. And there are things like that all over the connected health landscape. But as I said, going back and I'll give you an example from 19 in the 1990s when we first started doing that remote monitoring of heart failure thing that I talked about earlier. It was probably late '90s, early aughts. Uh, and once again, we partnered with our home care organization. The woman who ran it was a very visionary, wonderful partner to work with. I was running this Center for Connected Health at the time. So we said, we're going to do remote patient monitoring. We have this, get these monitors out and the nurses will be more efficient. The story we would say is that a nurse gets in the car and sees 5 heart failure patients in a day. Again, we can have that same one managing 50 or 100 people. The nurses didn't like that at all. Because why? Well, they get something out of that 5 person. Going in that person's home is an honor to them, et cetera, et cetera, et cetera. So didn't go over well at all. We had another project with them for wound care where they would photograph pictures of, take a digital camera, photograph a wound, and then feed it into a system to have a wound specialist give them advice. Didn't like that at all either. Felt like the person was looking over their shoulder. So there are all these examples where the tech made sense and the efficiency made sense, but the frontline workers weren't happy with it. And
Right, the
that's a
people who
change
go into
management.
healthcare are not electrified by words like scale.
Yeah. So it's a change management challenge, and that often doesn't rest with a CFO.
That's a very interesting thought that technologies really rely on people, no matter how you spin it, and the people have to be. Maybe that's the answer to why healthcare is behind on technology implementation. It's a certain kind of person who,
Yeah, and again, there's this. I called it the romanticized Marcus Welby before, but but that thinking, romanticized or not, really pervades our industry. Um, you are there to help the sick and suffering, and it seems weird that we might be able to put some kind of software between me and them and get that done better. And we just haven't got there yet.
I feel like that might be the
But
biggest test trick.
I like to tell a quick story. Depends on your age cohort of your listeners, but in 1982, uh, a cult classic, what now a cult classic, came out called Blade Runner, and um, and that was predicting the future in 2019. So we can really go back now and say what things did they get right and not. And of course,
Right.
flying
They released a
cars.
sequel to clean things up, but yeah,
Yeah, yeah, flying cars, not so much. But the one story I love to tell is when the main character, and he's kind of sweet on this lady, and he's having a drink in a bar and wants to talk to her, decides to make a video call. Now, in 1982, the idea of making a video call was pure science fiction. And so they got that right, that we would be able in 2019 to make video calls. The thing is, it goes to a phone booth to do it. So that's the problem with these, you know, scenarios where you're predicting the future. You get some of it right, but some of it not so much.
it's a good story. The Turing test
Yes.
from Blade Runner has definitely come back with a vengeance the past couple of years, with every new LLM that's released.
Yeah.
So you mentioned a sad story or a negative story about the nurse. Do you have any um, victory stories or positive anecdotes about
Well,
you've
most of
been in
those
this for
come
30
from patients.
years?
Yeah, most of them come from patients. This is another interesting thing about the U.S. healthcare system. I only say U.S. because it's the only country where I've actually delivered care. This may be true in all of uh, the Western world. I'm not sure, but in the U.S., the patient's convenience or patient service, I should say, is not something that we make a living on. Um, and so, if we were to leave it up to patients, telehealth would be a lot farther along because, as I said earlier, you get these kids, oh my God, I'm doing my visit in the middle of practice. Um, you have one of my favorite stories. These are simple things, but they make a huge difference. So, this is a woman who is disabled herself and has a special needs, like mid 20s-year-old son who's special needs and homebound and has a problem that we can take care of via video call. So think about all the steps that she has to go through to get out of her third floor apartment to come to the hospital to see a doctor. not only her own disability, but dealing with her special needs child. She was practically in tears when we did our first telehealth visit. So those stories abound. They exist. They abound. I have them from my own practice, but that's for the first 20 of my 30 years. That's what we in telehealth used as our leverage to say, oh, it's the best thing for patients. It saves travel. And of course, again, none of those things have a business model in U.S. healthcare, so people just shrugged their shoulders and moved on.
Hmm.
Um, but that's where I think the big success stories come. It's really improved access is what it boils down to. Improved quality of care because of improved access. Um, that doesn't necessarily mean more efficient care yet. It doesn't mean it costs less. I didn't say that. That's a hard uh, road to hoe. But improved access and improved quality is something we've been able to demonstrate over and over again.
I'd like to take a question from your book. Is there something you thought I would ask you but haven't?
I think you've been you've covered the waterfront. This has been fun, and I've enjoyed it tremendously.
Okay, good. So that bonus question. I actually found you because you're a LinkedIn top voice. Um,
Who knew?
you didn't know?
No, not really.
Oh, that's very fun. Okay, so but at any rate, you're very communicative, and you're
Yeah,
out
but I
there in
don't
the
know. I
public
guess I don't know
sphere.
what it means to be a top voice, but anyway.
LinkedIn likes to actually identify their top influencers as opposed to letting people figure it out on their own. So, and they do it by industry. That's my little plug for LinkedIn. Hopefully, they'll sponsor this episode. Anyway, you're far more communicative than most doctors or professors or people in academia, and that's a rare societal asset. I'm just curious. I'm curious how. I mean, you've been doing this for a long time. You've been in the public domain, out there advocating. Is just did that start before you became a doctor? Is that woven into the same tapestry?
No, I'm an introvert naturally, so I had to work hard at this whole thing. But I do. I think one of the personality traits I had, I've somewhat outgrown this. But when I started, remember, I was this kid who grew up in Vermont, simple family, great people, but I didn't. There was no Nobel laureate in my hometown, right? So I went to the University of Vermont, and I kind of bounced into the Harvard system after that, and I was like, oh, okay, this is kind of cool. And um, when you get to the point where if you view the world that way, and you get to the point where you have an insight, you tend to think that you're the last person with that insight, which is, of course, not true. I mean, starting telehealth in 1993, it was clearly not the last person with that insight. But nonetheless, that drove me to want to communicate a lot about it. And one of the things that I found over the years is that the vision, I've done a whole lot of different things, and it's every part of it has been learning and fun and exciting. The vision hasn't changed. As you said earlier, I don't think we've reached our potential. So the only way I know to do is to evangelize with data. And these days, with all these platforms, it's as the marketing people say, it's free, earned, owned, and paid, right? So this is owned. I mean, sure, why not?
Um, where can people find you online and in bookstores and I know there's so many
So,
outlets.
yeah, everything is on my website, joekvedar.com, but you can find me at a popular moniker on any of the social medias at jkvedar. This Instagram I have two. One of them is at dr kvedar, Dr. Kvedar. But thank you for asking. Yeah, mostly go to the website, and it's pretty much all there.
It certainly is. I've enjoyed consuming a lot of your content in anticipation of this interview, and I really thank you for your time.
Well, thank you. Look forward to connecting with you in the future.
Thanks so much.